Why don't we get started so we can get Amrit started on time? So
Sure.
good morning, everyone. Thank you for joining us for our continuing Grand Round series. Um, Today, it's my pleasure to introduce Dr. Amrit Rai, who's a comprehensive ophthalmologist who graduated from our program at the University of Toronto, where he was recognized with the Wojcicka Cup as the graduating resident with the highest academic achievement over the past 5 years, or the 5 years of residency. Since then, he's established himself as a cataract surgeon practicing at both Kensington and Trillium, and he is the surgical skills lead for our residency program, and the residents benefit greatly from his efforts organizing the wet labs. He has completed a certificate in global health from the University of Toronto and now spearheads a very important and very successful outreach program to Timmins, Ontario. And as his older brother, I still think his most impressive feat is that he's the only person I've ever known who's finished the entire Kumon math curriculum. Amrit, I think we're gonna find out today that how that Kumon's paid off for you.
That's right. We will be doing some math, but hopefully not too much. So let me just share my screen here. Thanks for that introduction, and thanks for the opportunity to speak. The title of my talk today is The Good, the Blur, and the Toric. And these are our objectives. So we're going to talk about how toric IOLs work and what is the impact of misalignment. We're going to differentiate lower order and higher order aberrations. We're going to look at the Zernike polynomials, that black box, and see where they fall short. And then we're also going to try to understand corneal asphericity, or the Q value. So there's a lot to cover today. Now, aberrations is a term that gets thrown around a lot when discussing various IOLs, particularly when talking about multifocal and extended depth of focus lenses. And personally, I was confused by all of the terms and all of the types of aberrations. I used to hear words like spherical aberration, coma, and wavefronts, and I would nod along, but not really understand what they meant. So today I hope to review some of the basics and clarify some of the points of confusion. Now, aberrations just means that light that is traveling through an optical system, like a lens or an eye, does not converge to a single focal point. And all optical systems will have some aberrations. We often think of this as parallel light rays not focusing to a single point. But in these examples, we're actually only talking about light of a single color or frequency. When we look at light that consists of multiple colors, as happens in the real patient experience, there's also chromatic aberration, which causes the dispersion of light. This is where we remember the mnemonic blue bends more. Lenses with lower refractive indices, like silicone or hydrophilic, will have less of this chromatic aberration. But for today's talk, we're going to focus on those monochromatic aberrations. Another term that gets thrown around a lot when talking about aberrations is wavefronts or wavefront analysis. So let's see where that comes from. And let's again start with this monochromatic red light traveling through this lens. We can see that the light rays do not focus to a single point. So how can we fix this? Well, let's just focus on this top ray here. And we can see that this top ray is focusing anterior or in front of the other light rays. And there are two ways that we can correct this. We could reduce the convergence power of the peripheral lens by changing the refractive index or changing its shape, or we could adjust the incoming light entering the eye so that it starts off a little bit diverging, like this. If we adjust that incoming ray of light just enough so that it's diverging as it enters our optical system, that will push the focal point further to the right. And we can do this similarly for all of the light rays that are entering this optical system so that we can get them to focus to a single point. Now, we can look at this process in reverse. We've been talking about rays of light converging to a single point. Now, instead, imagine a pinpoint light source at the fovea, for example, that emits a flash of light. This light would travel as an expanding wavefront emitted from the fovea, and as it travels through the eye, the wavefront is modified due to refraction. And these resultant wavefronts can take on many different shapes. If the light exits the optical system converging, then the wavefront will be concave. If the light exits with zero vergence, we'll have a perfectly flat wavefront. And if the light exits the optical system diverging, then the wavefronts will be convex. But in reality, optical systems tend to be imperfect and complex. And so the resultant wavefronts also tend to be more complex. And we need a way of simplifying and categorizing this complexity so that we can easily communicate with each other. And the first thing we can do is just add some color. Areas that are more advanced or further ahead are colored red, and areas that are delayed or held back are colored blue. Green represents neutral wavefront areas that are in the middle. We can think of this final complex wavefront like a soup. In the bowl, the soup appears complex with many different components, ingredients, and flavors. But we can break this soup down into its individual components, and we can keep track of the amount of each of those components. And then over time, we can develop enough experience that we're able to look at just a list of those individual components, and like a chef, we can already imagine what the final product will look like. Now, instead of carrots and potatoes, we have the Zernike polynomials, named after the Dutch physicist Fritz Zernike. These are our ingredients, or basic building blocks to create more complex wavefronts. And although I've only shown the first 5 rows here, this pyramid actually extends indefinitely with more and more complex shapes. But it's these first few rows that are the most relevant to ophthalmology. In ophthalmology, we tend to separate these polynomials into lower and higher order aberrations. The lower order aberrations include defocus, which includes hyperopic and myopic defocus, and primary astigmatism. These are classified as lower order aberrations because they're correctable with glasses. Everything from the 4th row onwards are deemed higher order aberrations. And in the past, you may have occasionally seen these all just referred to as irregular astigmatism. Within the higher order aberrations, coma and spherical aberration are the most clinically significant, the ones right in the middle. Now, but what do these diagrams actually mean? What are these colors? Is this like an axial map? No. You cannot just look at the topography and determine the exact wavefront. It helps, but it isn't the entire picture. The wavefront is limited by the pupil and also incorporates the lens aberrations. The wavefront is for the entire optical system, not just for the cornea. When you start looking into Zernike polynomials any further than what we've talked about so far, you start getting hit with these complex mathematical formulas and explanations. We're not going to do that today. I will provide some formulas as reference for the optics aficionados out there, but I'll try my best to represent all of these concepts graphically. While I've been using 2-dimensional representations of the wavefronts so far, these are actually 3-dimensional wavefronts that use color to represent the advanced and delayed areas of the wavefront. In this example, we have primary astigmatism on the left, which kind of looks like a Pringles chip or a saddle shape. And on the right, we have primary spherical aberration, which has this classic sombrero shape. These are some of our most basic building blocks, and they're technically referred to as Zernike modes. Using these building blocks, we can add the various Zernike modes to create more complex shapes. You can see that this resultant wavefront, which is the sum of primary astigmatism and primary spherical aberration, has aspects of both of those individual components. Now, some of these Zernike modes are rotationally symmetric. On the right, you can see how spherical aberration looks identical no matter how you spin it. So it can be represented by a single number, like plus 0.5, whereas modes like astigmatism need a magnitude and an axis. We can see that all of the central modes are rotationally symmetric. This includes piston, defocus, and spherical aberration. These modes can be represented by a single number, whereas any of the off-center modes are not rotationally symmetric, and so we need to provide an axis when we're talking about them. This includes astigmatism and coma. Now, what about piston and tilt, the aberrations right at the top of the Zernike pyramid? Most explanations you come across tend to ignore these two as if they don't exist. So let's see why that is. The reason piston and tilt are overlooked is because they do not induce curvature in the wavefront and therefore are not considered true aberrations. If we look at their 3D representation, we can see that neither piston nor tilt create any curvature in the final wavefront. I've included primary astigmatism as a counterexample, where you can see that the lines are curved. The first mode, called piston, corresponds to the constant wavefront error, which has no optical effect. Piston just shifts the wavefront forward or back, but importantly, there is no induced curvature, and it can be thought of as the average value of the wavefront error. Now let's look at tilt. Imagine we start with an aberration-free system, so we get a perfectly flat wavefront. Now tilt the lens and the object slightly, and you see that the image also tilts. But if our image plane, where we measure the wavefront, remains vertical, then the image wavefront appears tilted relative to that image plane. And so some of the wavefront is delayed, here in blue, and some is advanced relative to the vertical image plane. Tilt generally occurs when the object is not coaxial to the eye. If measuring wavefront error with a machine that is coaxial to the eye, there should be low levels of tilt. High levels of tilt may happen due to the contamination of higher order aberrations like coma with lower order aberrations like tilt. I'll go over that in more detail later on. But first, let's take a closer look at one of the lower order aberrations, astigmatism. A power cross can be used to represent the two primary meridians of any of our astigmatism. In positive cylinder form, the lesser number here represents the sphere power, and the difference between the two meridians represents the magnitude of the astigmatism. In this case, we have 1 diopter of astigmatism. If we take two power crosses, we can easily add them together by adding the vertical powers together and adding the horizontal powers together, like so. For a more clinical example, we can imagine what happens when we use toric IOLs to treat corneal astigmatism. Here we have a cornea with 2 diopters of width the rule astigmatism. It's steep vertically. And we have an IOL with 2 diopters of correction 90 degrees away. I put an asterisk here because technically this would be the IOL power in the corneal plane if we're adding them together, not the IOL plane. As we look at more examples on the next slides, we will be referring to the IOL power in the corneal plane just to keep the calculations simple. When we add these two power crosses together, we can see that the resultant astigmatism is null. But what happens when the axes are not conveniently aligned? What do you do in this situation? How do we add these numbers? In order to answer that question, we need to know what the power is along any meridian, not just the primary meridians. If we go a third of the way between 0 and 90 degrees, does that mean we have 1/3 of the power? And if we go 2/3 of the way, does that mean we have 2/3 of the power? Unfortunately, it's not a linear relationship and it doesn't work this way. So let's see how it actually works. Again, imagine starting with a simple power cross with 1 diopter of astigmatism, and this can be rotated to any angle. Again, we can draw in our intermediate arrows, and in fact, we can throw in as many arrows as we want, but that still doesn't represent every possible angle. A better way would be to imagine a circle that goes all the way around so that it does cover every possible angle. And then if we tilt this circle into the third dimension, we can represent the power at any point along the circle as the height of this curve. And now if we cut this curve and flatten it back out into 2 dimensions, we see a nice sinusoidal wave. Now there is an equation for this wave. This equation is actually found in the AO optics manual, but I said we would be avoiding complex formulas, so today I've just included it here for reference. This equation allows us to determine the power of the spherocylinder at any meridian, not just the primary ones. Here, we can graph the meridian of interest on the x-axis, so at any angle, and we can graph the power of this cylinder along the y-axis. We can then follow this yellow dot and see how the power changes at any angle. We can now clearly see that at 30 degrees, we have a quarter, or 0.25 of the power, not a third. At 45 degrees, we get half of our cylinder power. At 60 degrees, we have 3/4 of the total cylinder power, not 2/3. and at 90 degrees, we have the full cylinder power. Now, you may have heard that a toric IOL loses 100% of its astigmatic correction at 30 degrees of misalignment. We're going to see where this number comes from and why it's actually almost never applicable. And another question I've had is if a toric IOL loses astigmatic correction as it rotates, could we intentionally misalign an overpowered toric to fine-tune its effect? So let's see if we can answer these questions. So let's see what happens when we try to correct corneal astigmatism with a toric lens. Again, this orange curve represents a cornea with one diopter of width the rule astigmatism. So we have one diopter and the axis is 90. You can see the highest power occurring at that 90-degree mark. We can represent a toric IOL with one diopter of correction as flipped across the x-axis. If we add these two curves together, we get this green line, which represents the residual astigmatism. When the IOL is perfectly aligned, we can see that the orange and blue curves are mirror images of each other, and so the green curve is 0 at all angles. If we add the orange and blue, they're an equal distance from that x-axis, so it all sums to 0. We have 0 residual astigmatism. But let's see what happens as that IOL begins to rotate or misalign. This can be represented by shifting the blue curve to the right. As this happens, we can see how the resultant green curve starts to change. With 10 degrees of misalignment of this IOL, we start to develop some residual astigmatism at an axis of around 50 degrees. If we continue this IOL shift, at 30 degrees of misalignment, we notice something interesting. In the top right corner, we can see that the residual astigmatism has a magnitude now of exactly 1 diopter. But also, if we just look at our graph, we can see how the green curve looks exactly like the orange curve, just shifted down and to the right, or down to the left. This is where that statement that 30 degrees of misalignment causes the toric to lose 100% of its effect comes from. We can see that while the residual astigmatism does in fact have a magnitude of 1 diopter, equal to the original corneal astigmatism, the axis of this residual astigmatism has shifted from 90 degrees with the rule to 60 degrees, which is borderline oblique. So I wouldn't necessarily consider that as having no effect. And if our IOL is 90 degrees misaligned, well, then we can see that the residual astigmatism is quite large. It equals the sum of the corneal astigmatism and the toric cylinder power. So in this case, 2 diopters. We definitely don't want to do that. And then if we're misaligned by 180 degrees, that just brings us back to perfect alignment. Now you might say, how could you be 90 degrees off in your toric axis? Well, I've seen it happen based on confusion of how to read a biometry printout. Let's take a look at an example. In this case, if I used a T3 toric, there would be 0.38 diopters of residual astigmatism. If you choose a T4, then there would be 0.11 diopters of residual astigmatism. The error comes from thinking that your T4 should be implanted at an axis of 95 degrees instead of 5 degrees. When choosing an IOL, you should always use the red box to determine the strength of your toric. So whether you're going to choose a T3 or a T4, but then you should always look at this middle image in the green box for your toric axis alignment. And you can remember that the dots on your toric IOL should always be aligned with the steepest axis of your cornea, irrespective of if you're overcorrecting or undercorrecting. If you implant this T4 toric at 95 degrees, you will be 90 degrees off of your correct axis, which is 5, and you will more than double your patient's initial astigmatism. In this example, we can see that the T3 undercorrects and the T4 overcorrects the astigmatism, and that is almost always the case. The number highlighted here in the blue box represents the cylinder power in the IOL plane this time that would perfectly treat our corneal astigmatism. But it's rare that this power actually exists in the IOLs that are available to us. So for almost every patient, we need to decide between undercorrecting and overcorrecting the astigmatism. And so let's look at some examples of where the toric power does not match the corneal astigmatism or the corneal power. In this first example, we'll look at an overcorrection. So the IOL magnitude of 1.25 diopters. And we can see that even with 0 degrees of misalignment, we already start with 0.25 diopters of residual astigmatism. And the axis of this residual astigmatism is 180 degrees, which is 90 degrees away from our corneal axis. This is what we mean when we say we flip the axis. As the IOL rotates, we can see how the residual astigmatism changes. Interestingly, the residual astigmatism achieves a magnitude of 1 diopter at just 26 degrees of misalignment now, not that 30 degrees that we were accustomed to. And the residual astigmatism occurs at 51 degrees, not 90 degrees. So now this patient is well into oblique astigmatism territory. At 90 degrees of misalignment, we see we get the sum of 1 and 1.25 at 2.25 diopters of astigmatism. And let's look at what happens if we overcorrect by 0.5 diopters. Here again, at baseline, we'll have residual astigmatism of 0.5 diopters, even with 0 degrees of misalignment. And we reach that 1 diopter of residual astigmatism at just 21 degrees of misalignment. And again, the residual astigmatism has an axis of 41 degrees, well into oblique astigmatism territory. If we are 90 degrees misaligned, again, we get a huge amount of residual astigmatism. Now instead, let's look at what happens when we undercorrect our astigmatism. In this first example, we'll undercorrect by 0.25 diopters. And we can see that this time, we start with 0.25 diopters of with the rule astigmatism, the same axis as our original astigmatism. And even as it rotates, we reach that 1 diopter of residual astigmatism at 34 degrees of misalignment, but it also remains with the rule. Now it's not 90, but at least it's not 40. And lastly, if we undercorrect by 0.5 diopters, we can see that as the IOL rotates, it achieves 1 diopter of residual astigmatism at 38 degrees of misalignment, and that residual astigmatism has a with the rule axis of 76. Now let's look at this data summarized in a table. We will again assume that our cornea has 1 diopter of astigmatism. This first column here represents overcorrecting, undercorrecting, or perfect correction of your corneal astigmatism. This is the value that you would see in the residual astigmatism section of your biometry printout, because this is what happens with 0 degrees of misalignment. Your biometer is always going to assume that your toric alignment is perfect. This last column shows the angle of that null effect, the angle at which your residual astigmatism is back at 1 diopter, which matches what our original initial corneal astigmatism was. These are the same values that I had paused on when we viewed this graphically on the previous slides. In this case, higher numbers are better because they mean you have more wiggle room or more room for error before having your residual astigmatism reach that 1 diopter. I repeated this calculation for 0.5 and 0.75 diopters of residual astigmatism because this is the threshold that we generally consider for visually significant astigmatism. Here you can see that the perfectly correcting here and undercorrecting cluster around that 22 to 24 degree mark. And here you can see that across the board, the undercorrection by 0.25 diopters may provide a little bit of a sweet spot when your toric is misaligned. And here we'll plot the residual astigmatism on the y-axis and the IOL misalignment on the x-axis. And you can see for a perfectly matched toric IOL, as our misalignment increases, the amount of residual astigmatism also increases. Here, if we plot undercorrection by 0.25 and 0.5, we can see that there is a point where these cross over that neutral line. They start above, but over time, they actually result in less residual astigmatism. And if we add in the overcorrection lines in orange and red, we can see that these lines never cross that green line, which is the full correction. Now, large IOL misalignments are rare, so let's zoom into this portion of the graph. And this graph shows us that with overcorrection, we will always have more residual astigmatism, regardless of the amount of IOL misalignment. Whereas when we undercorrect, there is a crossover point where it has less residual astigmatism. And we can see the misalignment amount at which clinically significant residual astigmatism occurs. And you can see again, for the perfect correction and undercorrection, these cluster around that 22 to 24 degree range. Now, you may say that you're meticulous with your axis alignment, so misalignment doesn't occur. But I inputted a recent case I had into the ESCRS calculator, which gives access to multiple formulas at once. And you can see that while all three formulas agree on the toric power, in this case a T2, they disagree or they provide very different values for the recommended axis for my IOL. And this happens because these formulas all account for the impact of the posterior corneal astigmatism differently. Patients with higher amounts of corneal astigmatism are less affected by this variability. And even if you perfectly align your toric axis, there are multiple reasons why the intended axis may not be the ideal axis. Again, you could have miscalculation of the posterior corneal astigmatism. There could be inaccurate or fluctuating keratometry between measurements, unexpected surgically induced astigmatism, or variance in the astigmatism axes at different optical zones. So far, all of our examples and calculations have been for patients with just one diopter of corneal astigmatism. So let's see what happens with patients with higher amounts of astigmatism. Here we show the graphs for corneal astigmatism up to 5 diopters. Again, we'll zoom into this portion of the graph, and you can see that patients with high amounts of astigmatism will require high-powered torics. And this graph shows us that with high-powered torics, even small amounts of misalignment can result in clinically significant residual astigmatism. The takeaway point being that it is increasingly important to ensure your axis is aligned in cases with higher astigmatism. We can see that when the corneal astigmatism is only 1 diopter, here in purple, we get 0.75 diopters of residual astigmatism around that 22 degrees of misalignment. Whereas if you have 5 degrees of corneal astigmatism in red, then this occurs at just 4 degrees of misalignment. And these amounts can be quite subtle. Here are 3 IOLs with 0 degrees of misalignment. Up to 18% of eyes can have approximately 5 degrees of misalignment due to post-op rotation at their first post-op visit. And now these 2 outer IOLs are going to show you what counterclockwise and clockwise rotation of 5 degrees looks like. That's it. You can see how subtle that is. If your preoperative toric marks aren't positioned perfectly, you can see how easy it would be to be off by just 5 degrees, let alone any post-op rotation that may occur. Likewise, we can see what 10 degrees of misalignment looks like. It's not much. And then you can also have situations like this. This is a toric case that I had recently. We usually expect the toric marks to be aligned with the haptics. Here are the toric marks in red and the haptics marked with green. Here, the toric marks are a full 40 degrees away from the haptics. So errors in manufacturing can also occur. With all of these sources of error, it's surprising that some of our happiest patients are toric patients. I love using torics, and I use a lot of low-power torics. And I think many times these errors occur in opposite directions, so they cancel each other out. But every so often, these errors will align, and we get an unhappy patient. In those cases, websites like astigmatismfix.com or the Barrett RX formula can help determine how rotating an IOL or exchanging the IOL can reduce the residual astigmatism. In cases where you feel the axis calculation may not be the best, I suggest slightly undercorrecting your toric correction. I'm a big supporter of debulking the astigmatism. Now that's a lot about torics, so let's look at some higher order aberrations. Of all of the higher order aberrations, spherical aberration is one of the most important ones. And there can be a lot of confusion about spherical aberration, so I hope to provide some clarity today as to what is actually happening. Positive spherical aberration occurs when the peripheral light rays focus anterior to the paraxial light rays, or the central light rays. While this is commonly associated with spherical lenses, I put an asterisk here because aspheric lenses can also induce positive spherical aberration, as we'll see later. The positive spherical aberration leads to reduced contrast but increased depth of field. If we flatten the peripheral lens sufficiently, we can get an aspheric lens with 0 spherical aberration. All of the light rays focus to a single point. This provides the highest contrast images, but it does reduce our depth of field. and this is only possible with an aspheric lens. If we kept going and flattened the peripheral lens further, we can get negative spherical aberration, where the central light rays focus anterior to the peripheral light rays. Similar to positive spherical aberration, these lenses will have increased depth of field, but at the cost of reduced contrast. Now, I've been asked, is spherical aberration the same thing as asphericity or the Q coefficient? And usually a follow-up question is, if corneas are prolate, how do they cause positive spherical aberration? So let's try to answer those questions. We start with a perfectly spherical green lens in the middle, and we can make this more oblate by flattening the center, and make it more prolate by steepening the center. If we plot spherical aberration, we can see that spherical lenses in green and all of the oblate lenses in orange will have positive spherical aberration. However, the prolate side is a little bit more interesting because we can have prolate lenses that have positive, 0, or negative spherical aberration. So we need a better system of differentiating these lenses, a way to describe how prolate a lens is. And this is where the Q coefficient comes in. It describes the aspheric departure of a lens from a perfectly spherical surface, or how different it is from a perfect sphere. We see that the perfect sphere has a Q coefficient of 0, and the oblate lenses have positive Q coefficients, while the prolate lenses all have negative Q coefficients. In the setting of an eye, a prolate lens with 0 spherical aberration has a Q coefficient around minus 0.5. And the normal cornea has a Q coefficient around minus 0.27, which causes about plus 0.27 microns of spherical aberration. The fact that these numbers are the same but opposite sign is probably where some of the confusion comes from. And you can see from this diagram how a prolate cornea can cause positive spherical aberration. So let's see where this Q value, this number actually comes from. Again, we can start with a green sphere and imagine light rays coming in from this direction. We can flatten this sphere to create an oblate lens, or we can stretch this sphere to create a prolate lens, like so. And we could just try to remember that the sphere is 0, oblate lenses are positive, and prolate lenses are negative. But it's easy to forget or mix that up. So the other way would be to actually use the formula where the Q value comes from. We see that Q equals B squared over A squared minus 1. If B and A are the same, this fraction just simplifies to 1, and you see that Q equals 0. If B is greater than A, like in oblate lenses, then this fraction is going to be greater than 1, and so we end up with a positive number. And if B is less than A, then this fraction is going to be less than 1, and we're going to end up with a negative number. But again, realistically, no one's going to remember this formula. And so, instead, I like to rotate these shapes onto their side. And then I imagine that instead of the light coming in from the side, it's coming in from above. Now you can see that the orange oblate lens is above the green sphere, and the blue prolate lens is below that green sphere. And so if you draw it out like this, it's easier to remember that oblate is positive because it's above the sphere, and prolate is negative because it's below the sphere. And what about spherical aberration? Where does the number actually come from? It's simply the distance from the focal point of the most distal rays to the focal point of the most paraxial rays. So in this case, for this example, let's say plus 0.3 microns. And in the case where the distal rays focus further than the paraxial rays, then the spherical aberration will be negative. Now let's take a look at two identical lens systems. Both of these lenses have the exact same shape, so their Q coefficients are the same, minus 0.2, and they both have the exact same amount of spherical aberration, 0.3 microns. If we reduce the aperture size by blocking out some of the peripheral light rays, then higher order aberrations like spherical aberration will decrease in their magnitude because we've gotten rid of the most distal rays. This is why higher order aberrations are more relevant in patients with larger pupils. This also shows why there's no simple formula to convert from spherical aberration to Q coefficient. The Q coefficient has not changed. We've just changed the aperture size, but the spherical aberration does change. And that's because there are variables like aperture size and refractive index that impact spherical aberration. So in summary, spherical aberration is a wavefront whereas Q coefficient describes a lens shape. If we look at the physiologic optical system, we can see that a young cornea has positive spherical aberration of 0.27 on average, and the young phakic lens has about minus 0.2 spherical aberration on average. This leaves our total SA of the eye that is slightly positive, and some studies have shown that this may actually be ideal or preferable over zero spherical aberration. As patients age, we can see that the corneal spherical aberration stays the same, but the phakic lens starts to develop more positive SA, which drives the total SA of the eye more positive. And there is some benefit to this because it coincides with the incidence of presbyopia, and we know that having some positive SA can actually increase the depth of field. In post-myopic LASIK, the lenticular SA stays the same, but we can see that the corneal SA increases because the cornea has become more oblate. And as we saw earlier, all oblate lenses induce positive spherical aberration. So that drives the total SA of the eye up. In hyperopic LASIK, it's the opposite. The corneal SA decreases because the cornea becomes hyperprolate. Now, when we do cataract surgery, we generally try to reduce this total SA back close to zero. In normal eyes, we can do this easily with a negative SA IOL. Similarly, in post-myopic eyes, we can do this. A negative SA IOL works best to counteract that increased positive spherical aberration of the cornea. But if we did the same thing in post-hyperopic LASIK, this doesn't work so well because the cornea already has less SA, and this can result in a total SA that is negative. So instead, for these eyes, a neutral SA IOL, like the Invista, or an IOL with positive spherical aberration often works best. And for post-myopic LASIK, we can do even better by using an IOL with even more negative spherical aberration. Now we have to remember that our primary focus should still be to address the defocus and the astigmatism. The lower order aberrations are more important before we start worrying about correcting our higher order aberrations. Now this is going to be my busiest slide, but I wanted to include the IOL range and toric range for these lenses. This table summarizes the spherical aberration and IOL ranges for commonly used monofocals. We can see that the Clarion and the Technis both have negative SA, while the Invista IOL is neutral. The Ray 1 has options that come in positive, zero, and negative spherical aberration. The LAL starts with a negative SA that drifts upwards as adjustments are made to its spherical power. And the CT Lucia has this variable asphericity that depends on the distance from the center of the IOL. We'll see that in a second. Now, all IOLs are labeled according to their central power. So, example, a 20 diopter IOL has 20 diopters of power in the center. But that doesn't always mean that the entire IOL has the same power edge to edge. And in fact, it often does not. On this graph, we see that neutral SA IOLs, like the Invista, do in fact have constant power from edge to edge of the optical zone. But for positive spherical aberration lenses, the power actually increases as we move towards the periphery of the optic. If we think back to our diagram from before, we can see that the peripheral light rays focus anterior to the praxial light rays with positive SA. This means that the power in the periphery has to be higher than the central power. This is an example of our OHIP lens. For negative SA IOLs, the power decreases towards the periphery for the same reason, because the power in the periphery is less. That's why the focus point is further away. And in the Zeiss lens, it has variable SA that starts similar to negative SA, and then it increases back in the periphery. Now, the absolute amount that this power changes from the center to the periphery depends on the dioptric power of the lens. This effect is more amplified in higher powered IOLs, so it becomes more relevant in our hyperopic patients. And this concept also becomes relevant in cases where there may be IOL decentration or a large angle alpha, because this patient will not be looking through the center of their lens. Not only does this change the effective spherical equivalent power of the IOL, but it can also induce higher order aberrations like coma, which can be particularly bothersome for patients. In patients where I expect zonulopathy, like pseudoexfoliation or trauma, I'll often opt for a neutral SA IOL, so I know what power that patient is going to be looking through. Now in clinic, our topographers will often produce a wavefront analysis with a breakdown of those Zernike polynomials that we talked about earlier. This is like a soup recipe that we saw. we can see exactly how much of each Zernike mode is required to recreate the complex wavefront. And I was taught to look for RMS values greater than 0.3 to determine which aberrations are significant. But interpreting these charts was always an area of confusion for me. Sometimes it felt like the numbers I was seeing here didn't match up with my clinical findings of the patient. Let's take a closer look and see where that confusion arises from. Here again, we have a lens showing positive spherical aberration, and we can zoom in closer to see where the rays are actually focusing. We can see that there are three distinct focus points in this example: the peripheral focus, the middle focus, and the paraxial focus. And specifically, we can see that the peripheral focus is the most anterior, followed by the middle rays, followed by the paraxial rays, which are the most posterior. And recall that this is what spherical aberration looks like in the Zernike pyramid. And here it is in 3D, where we see that classic sombrero shape with a central bump. And if we label it, we can see that the paraxial rays in the center, the middle rays in the middle, and the peripheral rays at the periphery. But if we go back to this, we can see a clear linear relationship where the peripheral rays focus the peripheral rays focus the most anterior, and the paraxial rays focus the most posterior. So this central bump, which places the paraxial rays ahead of the middle rays, doesn't really make a lot of sense. It seems to imply that the paraxial rays focus ahead of the middle rays, which we see isn't quite true. And it's because that central bump should not actually be there. The central bump should be neutral green, and as we move more peripherally, the rays focus more anteriorly, as you can see on the right. So why is this happening? Why is there a bump here? And what are the consequences of this? If we go back to our food analogy, it is like walking into a kitchen to prepare a meal. One of the kitchens has pure sea salt, and the other kitchen only has garlic salt. Now, the recipe that you want to prepare calls for 3 teaspoons of salt. If you're using the pure salt, it's very easy. Just add 3 teaspoons. But if you're in the kitchen on the left and you only have access to the garlic salt, things get more complicated. The garlic is contaminating the salt. And so we would need to add 4 teaspoons of the garlic salt and somehow subtract 1 teaspoon of garlic flavor. The higher order Zernike modes, like spherical aberration and coma, are similarly contaminated by lower order aberrations. Now, again, I said that we wouldn't get into the math, but we do need to look at it briefly to see what's happening. And I'll simplify it to only the parts that we absolutely need. All of these Zernike modes have mathematical equations that describe them, but we'll focus on these primary 4: defocus, astigmatism, coma, and spherical aberration. The first thing you may notice is that the modes that are rotationally symmetric, defocus and spherical aberration, they don't have a trigonometric component because they are the same value regardless of the angle. Astigmatism and coma values change depending on the angle of interest. But for today's purpose, we only need to look at this actual polynomial portion of the equation, the portion that's inside the brackets. We can gray out the rest of the equation. We can see that the highest powered R term for each of these modes matches the row that the Zernike mode is in. And we start with a row of 0, 1, and 2, and we can see that defocus and astigmatism both have an R squared term. Coma in the third row has an R cubed term, and spherical aberration in the fourth row has an R to the power of 4 term. But here is where the issue arises. The higher order modes, like coma and spherical aberration, have contaminants. They also contain lower order modes like R and R squared. This is the garlic flavoring in the sea salt. And so let's again start with that equation for Zernike spherical aberration. If we draw out R4, we can see that it's a curve that opens upwards, and negative R squared is a parabolic curve that opens downwards because it's negative. Now we can stack these two curves on top of each other so that we can add them together. And we can see that this central curved portion of the defocus curve, when added to the green curve, bumps the center up, And the two wings on the sides will pull these wings down so that ultimately we get this classic sombrero shape that we're used to with Zernike spherical aberration. It's the R4 minus R squared that causes this shape. So we can again write that out like this. And now let's copy this down for a second and see what happens if we try to isolate for just pure spherical aberration. First thing we can do is move the defocus term over to the left, and so it becomes negative. And now we have R4 all by itself, and we want to isolate for this. So let's bring this all the way over here, and these two remain on this side. Now, because we have two negatives make a positive, so we can change this negative sign to a positive, and we flip this defocus. And so we end with pure spherical aberration is a combination of positive Zernike spherical aberration and myopic defocus. Okay, so what does all this mean in English? What it means for us is that if you have a patient who has pure spherical aberration and you measure their wavefront using Zernike polynomials, as our current topographers do, then your topographer will report positive Zernike spherical aberration and some myopic defocus. This myopic defocus is a contaminant. This downwards curve here is only there to balance out this central bump that we find in Zernike spherical aberration. And the same thing is happening with Zernike coma, which is often represented with these bumps. This crest here in this, this crest here in this valley here. Those bumps should not actually be there for pure coma, which is actually flat in the center. Those bumps artificially introduce tilt into the wavefront analysis. Now, this isn't to say that the Zernike polynomials are wrong. They just don't effectively distinguish between higher order and lower order aberrations because higher order and lower order aberrations are ophthalmology specific divisions, and the Zernike polynomials were not specifically created with ophthalmology in mind. In the future, we may have machines that utilize more accurate polynomials that can better distinguish between lower order and higher order aberrations. Dr. Damien Gatnel from France is doing a lot of work in this area. Let's look at some clinical examples. We'll start with a 34-year-old male with a minus 0.5 sphere on manifest refraction, so almost emmetropic. And a couple of things to point out are first, the corneal asphericity that we talked about earlier, minus 0.24, and the matching spherical aberration of 0.22 microns. So these are both very close to the average values for both. In the middle bottom here, we have our Zernike breakdown, and we can see that this measurement was taken at the 4 millimeter zone. It's important to know which zone we're talking about. So this means 4 millimeters, a 4 millimeter diameter circle. And the O6 here stands for the order, which means that we're looking at the first 6 rows of the Zernike pyramid. We can see that in this patient, there is some myopic defocus in the red here. And this piston is just a contaminant. But again, we don't need to worry about piston and tilt because these are not true aberrations. But overall, this aberration profile is quite good with minimal higher order aberrations. If this was a patient that we were thinking of getting ready for cataract surgery, I would be happy to consider any type of lens for this patient. But now let's take a look at an example of a 30-year-old male who has had myopic LASIK. And remember that myopic LASIK makes the cornea more oblate. We can see the flattening here. And so we would expect the spherical aberration to increase and the corneal asphericity to increase as well. And in fact, they do. We can see that here. The Q value is 2.52 and the corneal spherical aberration is 0.933. Now, this patient is objectively emmetropic after his LASIK. He sees 20/20 uncorrected at distance. However, you can also see from this picture that he has very large mesopic pupils, and he does notice and complain about halos at night. When we look at his Zernike breakdown at the 6 millimeter zone to start, we can see that there's 0.933 microns of spherical aberration. But look at this defocus term. It's almost 2.5 times as large, even though this patient is objectively emmetropic. They see 20/20 uncorrected at distance. And we would expected the defocus term to be close to 0. But this defocus is artifactual because it's the positive Zernike spherical aberration that always contains a myopic defocus contaminant. Prescribing this patient myopic glasses would not help. It would only make their vision worse. Their only problem here is really the spherical aberration. Now you can see that the total SA of the total aberration of the eye is 0.922 when we're using that 6 mm zone. And like we saw earlier, by shrinking the aperture to 4 mm, this value goes way down. So if we look at the 4 mm zone, then the aberrations decrease in amount. This is why the patient experiences less spherical aberration during the daytime when his pupils are smaller. You can see the photopic pupil here is 3.48 millimeters. So what are some take-home points for wavefront analysis? One, you want to make sure that you use the entire clinical picture to make decisions. Don't just base your decisions off what the machine is telling you, because there can be aberration or contamination from high order aberrations, which cause the lower order aberration numbers to not be 100% accurate. You also need to know that these can vary from machine to machine, so you do need to get familiar with your machine. Check the pupil size because larger pupils or larger zones are always going to have higher aberrations, and you want to ensure high quality testing. So make sure that the cornea is well lubricated because a dry cornea is going to make things a lot more complicated. In general, you can look for RMS values greater than 0.3, but again, we can see that this isn't always foolproof. And if there are significant higher order aberrations, counsel this patient prior to surgery, and maybe they're not the best candidate for a multifocal or an EDOF lens. And in the future, hopefully, we may have wavefront analysis that is better tailored to ophthalmology, that does a better job at differentiating between lower order aberrations and higher order aberrations. Thank you.
Okay, well, first of all, Amrit, that was fantastic. That's probably one of the most comprehensive and thorough talks that I've ever heard on that topic. So thank you for putting that together. Um, for the audience, now you understand where that Kumon comment came from. But question for you is, that's fantastic. But how are you using this in practice when you have let's say you have patients coming in for cataract consults, pre-ops, maybe IOL selection or counseling? How is this impacting what you do, both with respect to multifocal EDOF lenses, but even monofocal and toric lenses?
So, in terms of interpreting this, if if you're seeing a lot of higher order aberrations, that will suggest to me that maybe this patient isn't the best candidate for multifocal or an EDOF lens. And often I'll show the patient, even with their topography, if patients have irregular astigmatism, I'll go into Google, I'll type in corneal topography, and I'll show them this is what a regular bow tie looks like, and this is what your corneal topography looks like. And so I'll have a discussion with the patient. And then also understanding this idea of contamination in the Zernike modes helps me interpret when I see things like this, where the defocus is sort of off the charts in a patient that sees 20/20, right? In these cases, I lean back onto my clinical exam more so than just looking at these numbers. And even this spherical aberration is artifactually decreased. It would be higher if we had pure spherical aberration. So if I'm seeing a lot of higher order aberrations, my lower order aberrations are going to be affected by that. And so I don't necessarily rely on these.
Ahmed, I've got two questions for you.
Yes.
Again, very practical, clinical. So let's say patients had either a toric or an EDOF with a toric component with it. What's the best way? And those are two different areas, two different questions. What is the best way of refracting them? Can you put these patients at an autorefractor? Or do you have to just go to streak them and then do a refraction that way? And
Yeah, sorry.
my second,
Go ahead.
go ahead. I'm sorry. I'll ask you the second question after.
Um, I kind of reference this because in those lenses, like EDOF lenses, where you generally have a modification to the center of the lens, there may not be rings, but it has changed the shape of the lens centrally. these curves are going to be a lot more complicated, especially in this area close to the center of the IOL. So I don't generally recommend using an autorefractor. I think in these patients, it is important to do a manifest refraction because that central wavefront modifying zone of the IOL can really throw off the autorefraction. So it's much better to do a manifest refraction in those patients. And also understand that if your patient has small pupils, like they've got pinpoint pupils, maybe they're a glaucoma patient or they've been on pilocarpine or for whatever reason they just have small pupils, they may not have the full effect of that lens if they're blocking out most of the periphery of that lens.
The other question, thank you, that's great. The other question is, should all cataract patients be getting a topography to determine their wavefront aberrations?
I don't think all patients need a topography, but I think if you're going to be putting in anything like a toric IOL, a multifocal IOL, and EDOF, I think in those cases it is important to get a topography. Because if you're only using an IOL master, the IOL master will measure the astigmatism, but at that point you don't know, is this astigmatism regular or irregular? And so oftentimes the IOL master will recommend a toric IOL, maybe a T2, maybe even a T3. But then I look at my topography and I realize that this is not regular astigmatism and it's not going to be well suited to a toric IOL. If it's mildly asymmetric, then sometimes I like doing what I call debulking the astigmatism. So I may not use the total correction, but I'll try to just decrease it a little bit. Maybe instead of a T3, I'll bump it down to a T2 just to try to reduce the total amount of astigmatism a little bit, but not get rid of all of it because I know it's irregular astigmatism.
Thanks, Ahmed. Great talk.
Thank you.
There's a question from Dr. Curtis. Can the
Yes.
corneal astigmatism change significantly over time with disease or even just with the surgery so that the patient effectively has the wrong power lens or wrong axis in place? So, you put it in the right place now, but 10 years later, it's actually not perfectly aligned for the cornea then.
That is an excellent question. And yes, that does happen. Patients typically over time will drift to more against the rule astigmatism. And so sometimes there is even a train of thought of maybe leaving patients with a little bit of with the rule astigmatism because we know that over time they will drift in the against the rule astigmatism direction as they get older. Now, I wouldn't leave a lot of with the rule astigmatism. It also depends on the patient's age. Maybe if they're younger, they have more runway to have that shift. But also, patients come back to us a week later or a month later. And, you don't want to convince them, oh, your vision's going to be a lot better 5 years from now or 10 years. Just give it time, right? So you can leave a little bit of with the rule astigmatism for that effect, but I don't leave a lot and hope that it will get better. But it can shift over time. That is correct.
I did look into this a couple of years ago, and the drift towards against the rule is not necessarily linear. So for example, the pace is much greater in the 40s, for example, than in the 60s and 70s, which is our typical cataract population, 80s. In the cataract population, the shift is basically a quarter diopter against the rule every 10 years. So
Mhm.
you're looking at pretty small numbers. As Amrit saying. So there's another question here from Gaya Sivakumar. Amrit, when you are debulking the astigmatism, how are you counseling patients knowing that they may still require glasses?
So for these patients, I'll often show them, like in this case, this is a nice bow tie, but sometimes you see it and the bow tie is not so great. Maybe it's skewed a little bit. So I'll just pull up the topography ahead of time. I'm a big believer in if you tell the patient about these things before the surgery, it's an expectation and not a complication, right? If you don't tell them and then something happens, then the patient is upset. But I'll just pull up their topography and I'll pull up a topography off Google showing what regular bow ties look like. And I'll explain to the patient that, sometimes I tell them also that IOLs are like shoes, right? Sometimes these shoes come in size 10, 10 and a half, 11. There is no 10 and a quarter or 10 and three quarters. It just doesn't exist. And so oftentimes the same way with shoes, they come in half steps. And we have to choose what's going to be the best fit. And sometimes that means oversizing a little bit or undersizing a little bit. And we can't always get it a perfect fit. And the same thing happens with astigmatism. Most of our available IOLs, toric IOLs, come in 0.75 diopter steps for the astigmatism correction. So we often are trying to either overcorrect or undercorrect the astigmatism. So there can always be a little bit. And plus, our measurements may not be perfect, our formulas are not perfect, so there's always some room for error there.
Good. Well, I think that's the end of the questions. Amrit, thank you again. A very, very thorough talk that you presented on this morning. I hope the whole audience enjoyed it. We will sign off now. Thank you, everyone, for joining this morning.
Great. Thank you all.